Hello, welcome to Grand Rounds at University of Washington Medical Center. I am Dr. Ramasamy Bakthavatsalam, transplant surgeon. Today I am going to talk about pancreas transplantation. Pancreas transplantation is a solid organ transplantation which has been in practice since late 1970s. It is performed for patients with type 1 diabetes, and over the last few decades, improvement in surgical techniques, preservation technology, and immunosuppressive medications has improved the results of this transplantation and proved to be very good. Before going into the pancreas transplantation, we will just look at the structure of the pancreas and function of the pancreas. This pancreas gland is a long 15 centimeter gland which is situated in the upper part of the abdomen, deep inside. It has got a head, body, and a tail, and it weighs about 100 to 150 grams. It has got a complex blood supply which requires a significant amount of reconstruction prior to implantation into the recipient. It has got two components: exocrine component, which is responsible for enzymes; endocrine components responsible for the hormones. And this slide shows the exocrine component of the pancreas. About 90% of the pancreatic mass comprises of the exocrine component. It secretes enzymes mainly used for digestion of carbohydrates, fat, and protein. It also secretes bicarbonate and water, which is essential to neutralize the acid content of the stomach entering into the small bowel. These secretions has to go through the duct which passes through the center of the pancreas gland to enter into the gut. When you look at the endocrine component of the pancreas gland, it forms about 1% of the pancreatic mass. It comprises of islets of Langerhans. These are groups of cells which has its own blood supply, and the secretions from these cells directly enter into the blood circulation. These secretions are mainly hormones, namely insulin, glucagon, somatostatin, VIP, gastrin, and so forth. These hormones enter into the portal circulation, which is a special circulation which receives blood from the gut and the internal organs, and it goes to the liver first. In the liver, especially the insulin, about 50% of the insulin is used up for the local metabolism. Insulin is secreted in the proinsulin form, which is cleaved into insulin and C peptide. This C peptide is very useful when you measure it to assess the pancreatic function. The plasma half-life of this insulin is only 5 to 10 minutes. What happens when you have dysfunction of these islets and insulin secretion? Patients develop diabetes. Diabetes is a metabolic disorder involving the glucose metabolism, which is because of qualitative or quantitative lack of insulin. There are two types: type 1 diabetes, in which there is loss of islets ultimately leading to loss of insulin, possibly secondary to autoimmune disease or viral infection. Usually occurs in childhood, well before the age of 30 years. Whereas type 2, there is insulin secretion, but the patients have insulin resistance. This is the disease of the adults, increasingly seen in children, more common than type 1. In the next slide, we will see the complications of the long-standing diabetes. When the diabetes is long-standing, it has significant amount of complications. To start with, metabolic complications. Persistent high glucose levels lead on to ketoacidosis and lipid abnormalities, end up in accelerated atherosclerosis and vascular disease. Occasionally, significantly low glucose level can lead on to coma with a fatal outcome. Nephropathy. This is affection of the kidney from long-standing diabetes. About 30 to 40% of the patients with long-standing diabetes can develop this, which can ultimately lead to kidney failure. Neuropathy, this is affection of the nerves. It could be peripheral nerves or autonomic nerves. Peripheral nerves supply sensation to the limbs, and when this affection happens, patients develop tingling, numbness, and ultimately loss of sensation. This, along with the vascular problems, can lead on to ulcers, non-healing ulcers, and lead to loss of toes, digits, or amputation of the limbs. Autonomic nerves supply the internal organs, namely heart, lungs, stomach, gut, urinary tracts. When this system is affected, patients can develop gastroparesis, difficulty in emptying the bladder, and so on. Retinopathy is affection of the eyes. About 20,000 people are losing vision every year due to blindness from diabetes. Next is the vascular complications. Long-standing diabetes affects both small and large vessels, and these vessels could be in the heart, brain, or limbs, which leads on to heart attacks, stroke, and loss of limbs. As early as 1983, there was a trial conducted, namely DCCT trial, which is Diabetes Control and Complications Trial, which included 1,400 patients with type 1 diabetes of different duration. It was a randomized multicenter study which evaluated intense insulin therapy compared to a standard conventional management. It was very clear in the study there is 50% reduction in the nephropathy, neuropathy, and retinopathy in the intense insulin therapy group. The only side effect from this treatment is frequent episodes of low glucose requiring hospitalization. It was cost intensive, and also a proportion of these patients developed weight gain. When you look at the treatment of diabetes, other than exogenous insulin administration, there is islet cell transplantation and pancreas transplantation. Islets are the source of the insulin. How do they do the islet cell transplantation? Here you see in the picture a pancreas from a donor. This has to be procured and processed to isolate the islets, and these islets should be purified and ultimately injected into the recipient so that these islets gets implanted in the recipient to secrete insulin. The currently preferred site of injection of these islets is the liver. They have to access this liver vein with interventional technology and then inject it. What is the current state of islet cell transplantation? It has not reliably achieved long-term glucose control yet. The advantages of islet cell transplantation is there is no open surgery required, but still they need invasive interventional procedure to do the transplant. There is more than one pancreas needed for this procedure, and also multiple procedures may be needed to achieve insulin independence. These patients still require immunosuppression. The other alternative for transplant is the whole organ pancreas transplantation. This has been the standard treatment. More than 20,000 procedures have been performed to date. And this is the only surgical modality which has reliably achieved long-term glucose control in type 1 diabetics. Only one pancreas is needed. It definitely requires open operation. Immunosuppression is still part of the deal. When you look at the timeline, as early as 1920, Banting and Best discovered insulin, for which they were awarded Nobel Prize. In 1966, Kelly and Lillehei performed the first human pancreatic transplantation. In 1971, Gliedman suggested the enzyme portions of the pancreas could be drained into the urinary tract. This at least paved the way for success of the pancreas transplant, prior to which exocrine secretions of the pancreas has been the problem causing increased morbidity and mortality in this group of patients. Here is the volume of the pancreas transplant worldwide. About 1600 to 1800 procedures are performed every year, of which most of them are in USA. About 12 to 1400 are performed every year. Currently, the American Diabetic Association guidelines for pancreas transplants are type 1 diabetes with renal failure. Number 2, frequent acute and severe metabolic complications. Number 3, incapacitating clinical and emotional problems with exogenous insulin therapy. Number 4, consistent failure of insulin-based therapy to prevent acute complications. For the first indication of type 1 diabetes with renal failure, the patient needs pancreas along with the kidney transplantation. For the other 3, you just need pancreas transplant only. Patient selection. This is an important part of the pancreas transplantation. The ideal patient is a type 1 diabetic less than 50 years of age with a low cardiovascular risk profile. Age is not an absolute criteria. Long-standing diabetes causes varying degrees of cardiovascular problems in these patients. This has to be critically evaluated so that these patients go through the operation successfully. They should be free from malignancy. They should be free from infection. Obesity is an important factor. The outcome of pancreas transplant in obese patients, the results have been suboptimal. All these patients need psychosocial evaluation, as these patients need significant amount of support around the perioperative period. What are the ways the pancreas transplantation is done? Number 1, simultaneous pancreas and kidney transplant, where kidney and pancreas are transplanted at the same time. Number 2, there are some patients with high risk profile who receive a kidney transplant to start with, then after a while a pancreas transplant. This is pancreas after kidney transplant. There is a third group of patients who receive pancreas transplant alone. These patients have a normal renal function. The first category, the simultaneous pancreas and kidney transplant, comprises about 75% of the currently performed pancreas transplant. A brief look at the anatomy. Here is a picture from Netter anatomy book of the upper abdomen open. You see the liver being retracted there, stomach in the front, pancreas lies behind the stomach. In the next picture, the stomach has been removed to display the anatomy well for us. Here you see the pancreas lying across the abdomen. Here is the head, body and the tail. The blood supply to the pancreas is very complex. It shares the blood supply with the liver, and it has a segmental supply. The body and tail has a blood supply separate from the head and the neck along with the duodenum. This piece of small bowel is called duodenum. It shares the blood supply intimately with the blood supply of the head of the pancreas. This makes the operation complex, requiring significant amount of reconstruction prior to implanting this pancreas in the recipient. Once this is removed from the donor, this has to be looked at carefully prior to transplantation in the hospital. And if you look at it, there is the tail and body blood supply. Here is the head and duodenal blood supply. This has to be put together by a piece of blood vessel which also is acquired from the donor. Here is the finished product, the whole pancreas gland lying across. Here is the reconstructed artery. Here is the portal vein, and here is the piece of the duodenum, which is a gut, which is essential for draining the enzyme contents of the pancreas. In this picture, here is the abdomen, and the pancreas of the recipient stays deep in the abdomen, which is not going to be disturbed during the operation. The incision involves a midline incision in the lower abdomen or a lateral incision in the lower abdomen. Here you see the implanted pancreas. The pancreas blood vessels has been hooked to the blood vessels of the limbs. Here is the artery supplying the pancreas, vein draining the pancreas, and the enzyme component of the pancreas has been drained into the urinary bladder by attaching the gut to the bladder. When you drain the enzymes into the bladder, the advantages are it has been a safe procedure, and the enzymes which are secreted into the bladder are excreted, and these enzymes could be measured and used for monitoring rejection. One of the important ones is urinary amylase. And also this pancreas could be accessed through the bladder with a cystoscope to biopsy this organ. When you look at the disadvantages of this bladder drainage, it is a very unphysiological procedure. Bladder is not meant to deal with the enzymes, and also along with these enzymes they lose bicarbonate and water, which are essential secretions from the pancreas, which leads on to dehydration and acidosis in this group of patients. Because of the bicarbonate in the urine from this pancreas, it alters the pH, and occasionally it can activate the enzymes, leading on to inflammation, infection, bleeding, and also it can worsen the emptying problem of the bladder, which already exists in most of these patients. And also because of the emptying problem, these patients can develop inflammation of the pancreas called reflux pancreatitis. What is the other modality of draining these enzymes? It could be drained into the bowel itself. You can see in the picture, this is the donor small bowel called duodenum, which is drained into the recipient bowel. It is more physiological. It avoids dehydration and acidosis because the bicarbonate and water is absorbed. It avoids all the genitourinary complications which has been mentioned earlier. The disadvantages of this drainage: these patients can be more prone for diarrhea because there is large amount of bicarbonate and water, but usually this is self-limiting and it could be treated. If this anastomosis leaks, it could be a more complex problem because of infection, and you lose the ability of monitoring the urinary amylase, especially when the pancreas is performed alone. Next we come to the endocrine portions of the pancreas. This is the essential part of the whole transplant. The exocrine, we do not need it, but it comes with it in a whole organ transplant. When you look at the hormones, here this vein from the pancreas is hooked into the veins of the legs. It takes the whole insulin secretions into the general circulation of the patient, which causes high insulin levels, because in a physiological situation this normally goes into the portal vein, and the first pass effect happens in the liver, which is not the case here. These patients have known to have favorable lipid profiles. This high insulin levels temporarily causes low glucose levels in these patients, and it is self-limiting, and it improves over a period of time. The other modality of draining these hormones is portal drain. It is similar to the natural physiological way. Here you see the vein from the pancreas is drained into the portal vein, ultimately leading to the liver. Here the insulin from the pancreas has the first pass effect on the liver tissue, for the metabolism there. Pancreas transplant involves a donor organ. There is a tendency to reject. So, all these patients need immunosuppression. The standard immunosuppression for pancreas transplant involves induction with anti-T cell antibodies and maintenance immunosuppression with 2 or 3 drugs, commonly FK506 or cyclosporin, along with mycophenolate mofetil and steroid. Steroid sparing regimens are currently offered as well. What are the complications of pancreas transplant? Pancreas transplantation is one of the complex transplant. The main complications are bleeding, enzyme leak, and thrombosis of the graft, which means clotting of the whole pancreas graft. All these 3 requires reoperations. And wound issues, this could be just a simple infection, hernia, or a open wound requiring repeat procedures to fix it. Urinary tract issues and dehydration are much more common in bladder drained pancreas transplant. These complications we already mentioned earlier. About 30% of the patients who are drained into the bladder ultimately require conversion back into the bowel because of the aforementioned side effects. The advantages of pancreas transplant is in the insulin independence. These patients don't need insulin anymore, and for the first time in their life they enjoy freedom. It is shown to protect the kidneys and also improve the existing nephropathy. It is also shown to improve neuropathy and stabilize retinopathy. It is also shown to improve the microvascular and possibly macrovascular problems secondary to diabetes. Very importantly, all these patients enjoy improved quality of life and definitely increased life expectancy in the simultaneous pancreas and kidney group. Here is a slide showing the pancreas transplantation categories. In the green bar you see the simultaneous pancreas kidney group, and the blue and red bars are the pancreas only group. About 75% of the patients receive simultaneous pancreas kidney. When you look at the patient survival, about 90% of them are alive in all 3 groups at 3 years. And this data from SRTR shows the graft survival. At 5 years, at least 80% of the pancreas are still functioning in the simultaneous pancreas kidney group, and at least 50% of them are functioning in the other groups. In conclusion, pancreas transplant is a successful organ transplant which has improved the quality of life immensely in type 1 diabetics and also improves the longevity of these people, especially in the simultaneous pancreas kidney transplantation group. Thank you very much for attending Grand Rounds at the University of Washington Medical Center today. I have a couple of moments for questions.
How can someone be referred to the University of Washington for a pancreas transplant?
First of all, the patient should talk to their primary care physician and their endocrinologist, and then they should be able to help you to refer you to the nearest center. As far as the University of Washington Medical Center is concerned, there will be contact numbers at the end of this talk in the program. We would be happy to see you.
What does the future hold for pancreas transplantation?
Currently, the only surgical modality which has achieved reliably long-term glycemic control in these type 1 patients is pancreas transplant. Islet cell transplantation has been improving over the last few years and still not been optimal, and still considered experimental, and it's not available at all centers. and once it achieves the same results like pancreas transplant, probably that's the way to go. Till then, pancreas transplant holds good.
What's the expected recovery period after a pancreas transplant?
Following the transplant operation, usually the patient stays in the hospital for about 1 week. They need to be followed up in the clinic intensively about 2 times a week for about 6 to 8 weeks, and then they will be discharged to their primary care physician, and then they will be followed up at the University of Washington Medical Center every 3 months for the first year. From the recovery point of view, usually it takes about 2 to 3 months before they feel completely normal, because in the early part of the post-transplant phase, you have a lot of changes in the medications, and there are some side effects from the immunosuppression. Those things has to be adjusted. So, I will say probably about 2 to 3 months. Once again, thank you very much for attending the grand rounds at University of Washington Medical Center. Thank you.